Okay.
Okay.
Well, good afternoon, everyone. Only barely afternoon. I apologize in advance for any barking that may occur. We're at home at the moment, but I will try to mute the beagles as necessary. Good afternoon and welcome to the April 2021 quarterly Arkansas APCD Data Users Group. This is our 7th users group since we began back in early 2019, 2018, I forget, but it's our 7th one. For those of you who are new to these sessions and to the APCD, it's part of the Arkansas Healthcare Transparency Initiative and is administered by the Arkansas Center for Health Improvement, ACHI. The Arkansas APCD is comprised of private carrier and public payer medical, pharmacy, and dental claims. Additionally, the HTI enables the use of key data sets from the Arkansas Department of Health, including vital statistics data, and in other words, birth certificates, death certificates, hospital discharge data, emergency department data for self-pay and uninsured, cancer registry data, and medical marijuana cardholder data. For those of you who have used our data, you know we have a wide variety, and it's very interesting. We hope that you find today's session helpful. We invite you to ask questions at the end of each session and/or reach out to our team afterwards with any questions you may have. There'll be instructions along the way to help you do that. Why don't we go to the next slide? All right. Well, today's agenda was developed using survey responses from the last data users group. At the end of this session, you will receive an email with a survey in it. And we hope you take the time, excuse me, I'm gonna take my video off, not to distract you. We hope you take the time to complete the survey and provide suggestions for future users group topics. We want to address your issues and your questions. So the survey is a perfect way to communicate those concerns that you have or any help that you may require along the way. Some housekeeping for today's session. Between each section and at the end of the whole session, we'll ask for questions. Feel free to type your questions in the chat. Kathy, who is our host today, will collect them. We'll address them as we can get to them. At the end of today's session, we'll provide a link to our service desk application where you can enter any question. It's the best way to communicate with us. And the Arkansas APCD can be a complicated thing. You can also request time with our team to address specific questions you may have about how to use or interpret the data. We are here to help you. The link to this deck will be provided in the survey email you'll receive at the conclusion of the session. So it'll be posted on our website. Finally, the next data users group is scheduled for July 28, 2021. That too will be in the email you receive. So let's go over today's topics. We're going to talk about claims per member counts and methodology, events per payer examples and methodology, and then the latest APCD release information and data tips. Let's go to the next slide. My name is Kenley Money. I'm the Director of Information Systems Architecture at ACHI. I've been a speaker here before, and we'll also include Dr. Nicole Sanders, Assistant Director of Analytics, for her section. No other speakers today. Hopefully we can keep you entertained. All right, so we will begin with claims per month counts. Let's go to the next slide. Understanding the number of claims per member can provide valuable context for understanding cohorts, total services cost and spend, utilization, etc., any number of benefits. We're going to talk about 2 levels: unique claim counts by unique member, and then claims divided by members with claims. We will call this a rate. It's important to know how we define claims and members throughout this discussion. So unique members are represented by the study ID. And you might recall that Nicole, Dr. Sanders, introduced the study ID a couple of data users groups back. That deck is on the website, but the study ID is the submitting entity ID plus the member ID. And then unique claims, which are represented by the distinct claim numbers. And you see these field numbers here, MC004, PC004, DC004, medical, pharmacy, dental claim number. So let's go to the next slide and start looking at some numbers. Lots of little numbers. We'll do our best. Using these components, unique members and unique claims, we produced a frequency by members by number of claims. The 12 claim count groupings here are somewhat arbitrary. However, they provide a reasonably good picture of the number of claims by member. So let's look at an example and then we'll talk about the methodology. So if you look at the second row, you will see in the first, well, it's the first row, rows 1 and 2 of actual data, my apologies. You will see the number under the medical claims, 164,039, and those are the unique members based on the study ID that have one medical claim. And if you carry that over, 191,315 members have one pharmacy claim, 240,573 have one dental claim, and so forth. So like the next row, 466,335 members, unique members, have 2 to 5 pharmacy claims. Again, these 12 groups are a little arbitrary, but it gives you an idea of the number of claims per member and their distribution. So how we did this. First, let me tell you that this is for the year 2018. I initially built these numbers over all the data, all years, and the numbers were so large as to be distracting. So to represent what we did in this methodology, I restricted to the year 2018. So I selected you can see in the first bullet, I selected the claims based on the file type, medical, pharmacy, dental, using the service date in 2018. For pharmacy, it was the fill date. And then I grouped those claims by the study ID and the claim number. And then I counted the number of distinct claims by member for each file type and assigned a flag. And then that represented the number of claims, like there was a flag for 11 to 15 and a flag for 16 to 25, and categorized them for this report to produce the counts you see here. It's important to note this approach is at the claim level only, and it does not consider members with medical coverage who have not filed a claim. So let's look at these same numbers in a bar chart. Next slide. This is, we'll go through these somewhat quickly because you get the idea. It's the same numbers, just represented this way instead. So medical claims, next slide. Pharmacy claims, next slide. Dental claims. That's overall. Now let's look at some of our favorite submitting entities. Next slide. All right, we selected for this purpose Arkansas Blue Cross Blue Shield, Centene, also known as Ambetter or Celtic, Arkansas Medicaid, Humana, Caremark, and Delta Dental. But the first two here obviously are Arkansas Blue Cross Blue Shield and Centene. And their distribution of claims those two bar charts look a lot alike. The numbers represent using the same methodology, but restricted to the entity ID, which you see up here at the top, 83470 and 80799. These two are fairly straightforward. Let's look at the next one. Arkansas Medicaid is the first one here on the left, and it follows the same trajectory. You'll note that there are 26 members who have more than 1,000 claims in 2018. That 26 showed up on that first table. And these are most likely residents in skilled nursing facilities. They could be dually eligible. I did not stratify for that in this work. The Humana entity, and you should know there's several Humana entities in the Arkansas All Payer Claims Database. 73288 happened to be the one I selected for this. Its claim distribution is a little different. The age categories do not look like the three we just saw. I'm sorry, the number of claims, yeah, I apologize. Humana offers some Medicare Advantage plans, so it would be logical that some members would have a greater number of claims than the others, which the heavy numbers are basically in the 2 to 5 range. Next slide. Caremark and Delta Dental medical claims can't have all the funds. So Caremark tracks a bit like Humana. Our Caremark data is very interesting in that we receive member and claims data through Caremark for carriers that don't meet the qualifications, the minimum qualifications to participate in the Arkansas APCD. So we could have a carrier that did not meet the 2,000 member threshold, and so medical claims and or dental claims would not be submitted for them, but we could get their pharmacy claims through Caremark. And then there's Delta Dental, and that tracks a bit like the Blue Cross and Centene. And it's interesting that most members in 2018 had 2 to 5 claims, which would track with our regular dental cleaning schedule twice a year. Next slide. So that was interesting at the study ID level. And I thought I would venture out and do it at the hash ID level, and which is a little different. You'll recall, let's see, 2 or 3 data users groups before we did Dr. Sanders did a session on collisions, which talked a lot about the hash ID. We know that it's possible that 2 individuals of the same gender with very common names, John Smith, James Smith, Tom Smith, could end up with the same hash ID. So I expected a little fluctuation. I didn't account for that here. I just wanted to see what this looked like at the highest level. But still the numbers track pretty well. So let's look here. Again, on that first row, using the hash ID instead of the study ID, and which is the member ID and SEID. 112,000 members had 1 claim, medical claim. 109,000 had 1 pharmacy claim, and so forth. They track very similar, which helps support our understanding that the hash ID is, except in a few cases, is pretty clean. It's pretty clean. You shouldn't be afraid to use it without using some other data to support it, certainly, but it's pretty clean. I use the same process, the methodology here. It's just that I didn't use the study ID, I used the hash ID. Let's go to the next slide. I did the same sort of thing at the file type level. Those are the same numbers as in the table. That's medical. Let's go to the next slide. Pharmacy. Next slide. Dental. Now, I didn't provide charts at the SE level. You get the idea, I think, at this point. Happy to do that later or offline if you need it. So let's go to the next slide, Kathy. Yeah. Those were just straight claim counts by member. And the straight counts don't always tell the story. Claim counts by member can distort the level of utilization because submitting entities have varying coverage and or members. It looks like Blue Cross has all utilization, but how does it really compare to others? Is it really that much bigger? So we used a formula to create a rate so that we can look at the rate of claims to members instead of counts that would allow comparison to like level the playing field between these large and small carriers. Let's see some examples. Next slide. Tooling right through here. Okay. So I picked these 7 just to get an idea of what we can see using this process. Let's say first, let's compare 83470, which is the 5th row. That's US Able, AKA Arkansas Blue Cross Blue Shield. And if we compare it to 67369B in the 2nd row, which is a Cigna, it initially looks like this 83470 carrier would have a significantly greater claims to member association because of the claim counts. However, if you calculate the rate, you can see that it's actually very close. So the formula that we used here is essentially we divided the unique dental claims by the unique members in the data. It's very, very straightforward, and I'm sure most of you are way ahead of me. But this is there's a distinction here I'm going to make in just a second. So again, the unique members in this particular report were used based on study ID, not the hash ID. And this is for 2018. Using this, it's pretty easy to see the logic if you look at the Humana 73288 dental coverage. There are 1,869 members with dental claims, 3,309 dental claims for those 1,800s. The rate's 1.77, so almost a two to one. We expect that, of course, in dental claims, but that enables the comparison, a more level comparison of it to the other plans, say Delta Dental right above. Let's go to the next slide. We are very often asked by our data users how to identify members with medical, pharmacy, and/or dental coverage who don't have any claims. Just because you have coverage doesn't mean you're filing a claim for whatever reason. And here we're going to discuss how these rates can be here we will discuss rates calculated to understand the claims in this scenario when members may or may not have a claim. The formula for it is just like the other, but it's for members who may or may not have a claim, where the other was they had to have a claim. And as before, we're using the study ID, and this is for 2018. The key here are these last three fields in this third bullet in the member file: MEO 18, 19, and 20. And their definition in the data submission guide is to identify the types of member services that the plan provides. Doesn't mean that the services have been provided, but what it would cover. So an individual on the member file can have one of these flags, but it doesn't mean, this field does not mean that they have claims. Let's go to the next slide. So we've talked about these fields before, but given what we're talking about now, it bears repeating. So the value that we use to indicate the presence of this type of coverage is a 1 in each of these fields, and you can see the value definition. 1 equals yes, has that coverage. 2, 3, 4, and 5. And this sounds pretty straightforward. However, let's go to the next slide. I've told you, those of you who've talked to us about this before, you know we say use with caution. And we'll tell those who are new to this, use with caution. Because inherently, not all submitting entities are able to populate these fields well, because their claims and plan systems don't communicate with each other. And also sometimes there are data quality issues and they're very hard to catch as data comes in. Quite often we find them later once we are able to put data together contextually. So, and unfortunately at this time, there's not a solid workaround for this, but let's look at the data tip. So Kathy, if you wouldn't mind clicking on the data tip, this button should be live, yay. And there's a tip within this tip, but we'll start with this tip. All right, this data tip talks about how in some cases the submitting entity will send a record for each type of coverage: one for medical coverage, a member record for medical, a member record for pharmacy, a member record for dental. Not always. Usually, if a plan covers all three, sometimes they just send one record and set these flags accordingly. But you can see in this example here how this is WellCare. They sent 3 records. So what this data tip, let's see here. This happens to be for different. Yeah, I'm sorry, I'm reading. I was trying to catch up with myself. All right. So it's important to take a look at this data tip. This data tip will also be expanded to include some additional concerns that we're discussing here, where if there are issues or data quality problems that could cause these to not align well. That said, Kathy, let's click there. Yes, thank you. So a while back, once we began to understand how problematic these 3 fields were, we added 3 fields to the member file, and they are, you can see here, they are ME018A, 19A, and 20A. And we have created these fields so to save you some work. And each of these fields means that the member has those types of claims present in that time period for that time. For example, if a member is active, they have an active membership in 2018, then if they have a claim in 2018, this field is going to be set to 1, meaning there's a claim, and it will save you some joins along the way. And you can, at this time, I don't recommend it because we haven't worked through the workaround, but it's possible to associate ME018 with ME018A and begin to understand who might have coverage and who has claims. However, again, use with caution, caution, caution. And I recommend, if you want to do that, let's talk about it, because there are nuances that could impact the quality of the work if you are identifying members without claims using these fields. So you'll get closer, but still, I will tell you, we are doing 2 things. We are continuing to explore the relationship between these fields, ME018 and ME018A, to build a stronger set of rules that can help the data users at least sift through some data quality. For example, Arkansas Medicaid provides to us medical claims, pharmacy claims, and dental claims. But because their systems don't talk to each other, the ME018, the flag for medical claims, it's set to 1, which is correct. But 19 for pharmacy and 20 for dental are set to 3, which means unknown. So those are the types of nuances we are working to identify and provide some workarounds for you so that you can use these fields better. We are also beginning a process to work with the submitters to see if we can't get some of these corrected. So that said, if you must do any calculations or build a rate or anything like that using these fields, because you need to understand if members don't have coverage, but if they have coverage but they don't have claims, use with caution at this time. So that concludes my part. Does anybody have any questions, or would you like to save them to the end?
We have 2 questions in the chat, Kinley.
Would you read them, please?
Certainly. From Joseph, we have, for cancer patients, sometimes they switch to Medicare or even Medicaid after diagnosis because of financial toxicity. How do we track them over time?
How do you track them over time? Well, I'll ponder, but my initial recommendation is to associate the cancer registry patient to the Medicare and the Medicaid claims using the hash ID. And once you have identified the hash IDs associated with your cohort, your cancer registry cohort, then you can mine the Medicaid and Medicare data, even the private carrier data, but it's probably not there, over time to understand, to hopefully answer the questions that you have. But use your hash ID, which is remember, your hash ID is the APCD unique ID, ME998, plus member gender, ME013.
Okay,
Next.
and from Claire, is ME018A flag for any time within the given plan timeframe? For example, the example was 2018, but if the plan was from 1/1/2017 to present, Would a yes on this flag mean at least one flag
Yes. Yes.
for 2017 is present?
Yes.
Okay. Or at least one claim.
Yeah.
Flags don't equal claims, Claire. The
It's
flag is just whether they
presence.
had coverage.
Right. Presence of a claim. Mhm.
Yeah. Yeah.
Those are great questions. Well, all right. Why don't we turn it over to Nicole? Let's change to the next slide. Should be a.
We have one quick question from Brian Fair. Are IDs generated based on just unique names in the raw claims?
Our member IDs.
Nope, just says IDs. You want to clarify, Brian?
Yeah. Yeah. So can you hear me?
Yep.
So each person has a unique ID. Is that generated just based upon their name? And so I think, like you said, hinted earlier, you might have people with the same names
Okay.
getting incorrectly linked, or is it using data like social security number to also kind of make sure they're unique?
Okay. The hash ID, which, as I said just a moment ago, is the concatenation of two fields within the APCD data, but the ME998 plus ME013, which is the APCD unique ID and gender. The unique ID is a concatenation of the member's last name and date of birth, and then it's processed through a hashing routine to create the multi-character numeric value that you'll see in your data. So this is because when the enabling legislation was passed for the APCD, PII was prohibited, so that the carriers could not send us PII, which would mean name, address, a social, date of birth, etc. The hash ID, or the APCD unique ID, ME998, was became the representative of the individual, and it is the concatenated last name and date of birth. In fact, there toward the end, I'm going to show a deck. I'm going to show a link to a deck that could help this for those of you who aren't terribly familiar. We have found over time that only about 3% of the hash IDs are problematic in that they have collisions like this. So why don't I stop there, and then I'll come back to it when we get to the deck, the reference information that will be helpful to you. Okay. So I'm going to turn it over to Nicole, Dr. Nicole Sanders.
Hi, thank you, Kinley. Kathy, we can just jump into the next slide. Okay, so I think first let's go over some terminology that we use, at least on our analytics team, especially when we're meeting other teams and determining our study questions or the questions of interest. Typically, those of us who are elbows deep in data tend to think in terms of the raw data available. So when a policy person or an MD or a PI asks us about studying a procedure, we may jump to procedure code when they might actually be interested in a lot more. So what is a procedure? Specifically, for a lot of us, we're thinking procedure codes, which would be MC055 in the medical claims, HCPCS or CPT codes, or maybe MC058 to MC058L, which would be the ICD-9 or 10 CM procedure codes. I do want to make a point here that you need to note that MC055 is distinct per claim line within a claim number. And MC058 through 58L, those are not distinct across within the claim, much like how diagnosis codes are not distinct within a claim. So you need to be aware of that when you are thinking about how you're going to count your procedures. So more generally though, when people say, or Non-data people say procedures. They're talking about everything involved in a healthcare episode or event, which could be just a single claim with multiple lines, like a wellness visit, or a multiple claims from different service types, like a facility claim or a professional claim, which you could see with a colonoscopy, or multiple related claims over a period of time, like with a delivery. So, Kathy, you can go to the next slide. I'm going to use EKGs as an example for both of these for counting procedures versus what I would call an event. One of the best ways to make sure that everyone is in agreement is to clearly define the numerator and how it will be counted. So in this particular example, if you were counting procedures, the numerator is going to be the EKG procedure codes. So how many EKGs per patient? And the denominator obviously would be your patient. Here we have two, oh, I forgot, I can't use my mouse. We have two different patients from two different payers. We have,
Sorry,
it's okay.
I clicked. Shouldn't have clicked. Go ahead.
We have, for the first person, you can see that's one single claim with multiple claim lines. And for EKGs, in these examples, we have 93005, which is actually just the tracing of an EKG, and 93010, which would be an interpretation and report. And let me point out, when you're looking at this type of stuff, you need to confer with your subject matter expert, whether it's an MD or even a coding billing person. They can tell you a lot. So you can see that this particular person, the first person, had two of the tracing onlys and one of the interpretation reports. You need to decide if you care about separating out the interpretation or the tracing. That's something you need to decide. Let's look at the second person. This person has the two claims with the same procedure code. What you need to figure out is, even though the APCD subscription that everybody gets is versioned, it is based on what the payer, the submitter, tells us how they're going to version it, how they adjudicate, but that they have to stick to that too. It could be that this example is a situation where that first claim line was backed out or canceled, and then they resubmitted it. It's really hard to tell sometimes. So that's something you should consider. Let's go ahead and assume that you want to know each of those. You're including 93005 as a single event and 93010 as a single event. You'd like to count, I'm sorry, procedure. You want to count each instance as a procedure. So let's go to the next slide. Thank you. So if you wanted to count procedures that way, you could count the distinct submitter, MC001, with member ID, claim number, and claim line. If you didn't care, if you wanted to treat, in this case, the tracing only and the interpretation and report as being a procedure, then that's what you would count. If you did want to separate out the two, then obviously you would group it by the MC055. And sometimes you would want to do that with things like comparing screening and diagnostic procedures, maybe. One of the other examples I had been considering was mammograms. or like colonoscopies. There are, of course, always, when working with the APCD data, considerations. So how many similar procedure codes might appear on the same claim or on the same day? Like the fact that you can have multiple EKGs during one hospital visit or doctor's appointment if they're just testing your EKG, looking at it over time. You also need to know how different payers reimburse. Maybe they only let a certain number of EKGs occur in one visit. Again, like I said, maybe a submitter assigned a new claim number during adjudication, which is rare for medical claims. And also the subscription's versioned to avoid those situations, but rely on the submitter. And of course, if you run into things like this, you can get in touch with the APCD with Trang and Kinley.
Yeah, our
What you-
technical support, absolutely.
Yes, thank you. Okay. You can get in touch with technical support and they can help you figure that kind of stuff out, which we've done many times. Okay, next slide, please. So now let's talk about what if you wanted to ask the question of how many emergency room visits included an EKG procedure. So we're looking at the same example before. Let's say that all of these you've pulled a bunch of ED related claims, and then you specifically pulled out the ones that you know that contained your procedure codes of interest. Now this time you don't care if they had multiple EKGs. You just want to flag emergency room visits that had a EKG. So we can go to the next slide. And one way to do this is to count distinct submitter member IDs and date of services. If you go back up, Kathy, to the last slide. So you can see by doing that, you don't have to worry about situations like the second patient where they had these two different claim types. What you care about is that there was a visit, or claim numbers, I'm sorry. There was a visit on the 30th that did have an EKG procedure occur. So you wouldn't double count anything in this situation. It's really, obviously, it's a lot easier to count events than it is when you're trying to figure out how to count procedures specifically. But you will become the expert about that particular procedure or event once you start digging into it. Okay, next slide again. So considerations for this. So if you did want to count perhaps distinct or events that occurred over time, over what we call the healthcare experience of an individual, not just when they were on a particular payer, but over a year. That's what you really care about, is this person over this particular year. In that case, that's where you want to use the hash ID, which was, as Kinley said, ME998 with ME013, or if you've already linked, because again, hash ID is, well, the ME998 is only in the enrollment table. You have to link it to your claims using the study ID Kinley mentioned, which is submitter and member ID. Once you have that on your claim, you can count individuals that way. So let's see. Oh, one other thing that I did not think to add on the slide was that you need to watch out for events that involve a facility admission. So like instead of an ED visit, what if there's an inpatient stay or a nursing home stay? Then you need to think about your question. do you want to count an event based on an admission or based on when that occurred? The EKG is a good example again. If you had a patient who was who was admitted to a hospital and they needed their heart monitored every day for the whole length of time that they were in there, you would not want to use, well, you would count it the same way here, based on date of service. But if you wanted to only count or only identify events where there was an admission and during that time they had an EKG, then you would use MC018, which is admission date. So always be on the lookout for situations like that and think very carefully about your question and what you're trying to define as your numerator event. I think that's all I have if anybody has any questions.
I don't see any in the chat.
Excellent.
Okay. If you have any questions later, you can always email us. If you're talking, Kenley.
I know, it just told me I was muted. Okay, thank you. Thank you, Nicole. That was terrific. Nicole always gets elbow deep into the data and it's great fun. All right, let's go to the next slide. We are going to talk about the latest release. We released the latest APCD in February of this year, just after the January data users group. I wanted to talk about it then, but I couldn't. The data coverage is January 1st, 2013 through June 30, 2020. You'll see on this slide, there's this release information. I highly recommend that you review that. Kathy, would you click on it? It should be clickable. And of course, oh yes, okay. So let's go down to the next section. I think we're going to rearrange this page, but if you'll stop there and you'll see Arkansas APCD resources, use and available data. This section has been updated with the documents that relate to the latest build, the release notes. Don't click there. And you'll see there are more counts, updated counts with the latest data in it. Number 6 is universe counts. That gives a good overview of counts by year for all of the claim types, including the HTI data, the vital statistics, hospital data, medical marijuana, etc. But to address further the question we received a few moments ago about the IDs, Kathy, would you click on data attributes number 2? This is it doesn't get updated, but it's very relevant to any release. And this deck is recommended for any new user, but especially new users. And what it will do is give you an overview of the types of data available, but also how to link the data, how to create your study ID, how to find your hash IDs and all of the data available in the APCD. So I highly recommend that you review this. If you have any questions, reach back out to us. Your questions allow us to fine tune the information. If something isn't clear, it's so helpful if you ask us. But I wanted to take a minute to look at this particular deck. If you'll go back, Kathy, and click on number 1, release notes. So each build, we started producing these, and obviously there are 2, but each build there hereafter will have one. And the one for the February build is there. You can click on that. A couple of pages long. It describes, there's an introduction. It describes our naming convention. You might hear us talk about the latest build as 20B or 21A, etc. And it'll explain why. So go down just a little. some high-level coverage information, and then the next page 3, toward just about the end, are the notes about the problematic submitting entities. The last build from August of 2020, we began, well, we had omitted several entities because their data quality was so bad, but we have been able to include them all except for one. We only have one submitting entity that we haven't included in the build, and that's Lincoln, and they provide dental data. But in this document, you can look at all the carriers and that had problems that were previously excluded but are now included. Some were included because they still have some problems. And like the Humanas, 1, 2, wait, Kathy, you don't have to go much further. Right there's fine. 12282, they're like 5 Humana entities. They resubmitted all their pharmacy claims. They resubmitted all their data, and it was fine, except that the pharmacy claims have an issue. But there's a workaround in the data tips that will enable you to look at that and still use the pharmacy claims. So Kathy, why don't we back out to the deck, and let's go down to the next slide. So I summarized the new submitters and and when I say new submitters, I mean submitters that weren't there before but are there now, whether we had them before or not. And this is what's in the release notes, but it's just at a higher level. If you want to go to the deck, the users group deck, to find this information, fine. Or if you want to go to the release notes, that's fine too. But these are here for your use if you need them. So I'd like to skip down there, like 5 pages of these, and let's go to the last page, or next page. Don't forget, always look at your data tips when you start using this data, and of course, reach out to us. Next. Okay. Whenever you're using your data, don't forget to use our data dictionaries and the tip sheets or your data tips. And I featured some tips here today, but you can look at them at your leisure. But let's look at the last one, PC043. This is the data tip that is related to the pharmacy issue that I just described for Humana. And in this particular thing, what Humana did was when they built their data and sent their pharmacy data and sent it to us in this resubmission, something is awry. It was probably a bad join, don't know. But the PC043 and PC050, which are provider IDs, prescribing provider ID and prescribing provider license number, they're completely and totally invalid, which created what looks like a whole lot of duplicate records. And so you can use this data, and because there were so many duplicate records, the versioning, we found that the versioning or the adjudication was bad. So we backed up and changed the versioning a little bit to ignore, and the deduplication to ignore these 2 fields so that you can group better. So what you'll need to do is, if you use Humana pharmacy data, is to look at it, and if there's a lot of duplication, then you can dedupe yourself, but eliminate those 2 fields. They are resubmitting their data with corrected fields. So hopefully you don't need those 2 fields. License number is not one that's highly used. So, but that's an example of how to use a data tip or an issue with and work around with things that we have seen in the data. Hopefully by the next time we meet, this one will be resolved. Won't that be great? All right, Kathy, if you'll go back to the deck. All right, next slide. As always, reach out to us with questions. You can do this through our technical support email. This is helpful because we use a product called Atlassian Jira, and it captures all of your requests for easy identification and searchability, and we can build an issues log or most frequently asked questions as part of it. Next slide. I think that's it. Does anybody have any questions after all? Kathy?
I do
Yeah.
not see any in the chat.
All right, well, while someone's thinking of a question, let's go to the very last slide, which is call to action. Oop, go back, I'm sorry. Next to the last slide, which is call to action. Sign up for our newsletter, track us on social media, blog posts, and take our survey. You will get an email. And our next data users group is July 28th, 2021. If that's it, Kathy, if there are no questions, let's let everyone go 7 minutes early.
Ooh. Just time to eat lunch.
That's right. Thank you, everybody. Please, please, please take the survey and send us any questions. We'll all get better. Thank you.
Thank you.